اوكي. السلام عليكم واهلا وسهلا فيكم بالجلسة السابعة من الاونلاين كريتيكال ابريزل جورنال كلوب. معنا الدكتور فارس الأحدب، ثاني جلسة من السيستماتيك ريفيو كريتيكال ابريزل جورنال كلوب. معكم عمار صابوني، انا مودريتور من خريج من جامعة القاهرة ومن سامز اونلاين كورسز سب كوميتي. والدكتور فارس راح يعرفنا عن دراسة اليوم ويكون معنا البرزنتر. بيجوز نحن جزء من الجلسة اليوم تكون بالإنجليش، فيا ريت إذا أي حدا عنده أي مشاكل بفهم اللغة أو بأي مصطلحات يبعت لي question أو يرفع إيده على البلاتفورم. مرة ثانية أهلا وسهلا فيكم باسم سامز Education Committee. وتفضل دكتور فارس.
شكرا سامر، عفوا شكرا عمار. Okay, so far we don't have ما عندنا حدا بيحكي انجليزي، فرح نضل عربي هلا. شكرا لكم لحضوركم يا جماعه واهلا وسهلا فيكم بهالجلسه. مثل ما شفتوا الماتيريال بعثناها بالبدايه، فنحن بالبدايه رح نبلش بكلينيكال سيناريو وبعدها رح ننتقل بالخطوات، نلاقي دراسه وبعدين نقيم الدراسه مع بعض وبعدين نشوف كيف رح نرجع لكلينيكال سيناريو ونطبقها على المريض تبعنا. فانتم هلا بدكم تعتبروا حالكم انكم هوسبيتالست او انترنست، طبيب داخليه بمشفى بكوميونتي هوسبيتال بالمدينه تبعك، وفي مريضه اجتك ككونسلت. هي المريضه هي هلا عمرها 86 سنه، في عندها elective total knee arthroplasty، في عندها تغيير ركبه كامل خلال 5 ايام، فهن عم يحضروها هلا بشكل جراحي، عم يجهزوها العمليه الجراحيه. فالطبيب التخدير المسؤول عنها بعثنا الكونسلت لحتى يشوف من الناحيه القلبيه هل في داعي نغير في شيء فيها، وعنده كان سؤال محدد بهالموضوع. هلا هي المريضه هو قال لك طبيب داخليه انه في عندها هايبرتنشن، عندها دايابيتيز، كوليستروليميا، وعندها ستروك من 2 سنين صار معها. ف يعني 86 سنه طبيعي رح يكون في عندها كثير شغلات سابقه. بس حاليا المريضه ما في عندها اي شكوى غير مشكله الركبه تبعها. ومن ناحيه الفيتال ساينس تبعها بالذات الضغط تبعها كان واطي شوي، العالي كان واطي شوي، ونبض طبيعي، وكل شيء ثاني طبيعي، ما كان في عندها اي مشاكل ثانيه. بس طبيب التخدير اطباء الجراحه بيكونوا قالوا له انه شفنا الناحيه القلبيه لهالمريضه مشان ما تكون العمليه خطيره على حياتها بيزكلي. فطبيب التخدير طلب منك انت كونك عندك خبره بالداخليه بالمجال الباطني، انه هل في داعي نبلشها على بيتا بلوكر بالذات بيزوبرولول. هو كان رايه انه اذا بندخلها للبيزوبرولول بيري اوبرتيفلي مشان الكارديوفاسكولار ريسك للمريضه، فهذا الشيء احتمال نحن نخفف من بعض المشاكل، رح نحكي عنهم بالضبط شو هن. فهذا كان رأيه. بس انت you call the anesthetist to discuss the strategy، بعدين بتقول انه الانستيست انه انت ما برأيك ما في داعي للبيزوبرولول، خاصة يعني بضوء البوست ترايل اللي هي ب 2008 تقريبا انتشرت. فانت بهالدراسه هي شفت انه البيتا بلوكر بيقلل من الريسك من كارديال انفاركشن، بس المشكله انه هو بيرفع من الديث ريت، بيرفع نون فيتال ستروك ريسك، بيزيد الهايبوتنشن، هي اصلا عندها هايبوتنشن، وبيعمل براديكارديا. هلا هو عم يناقشك فبيقول لك انه طب في ترايل ثانيه كمان على نفس الموضوع على البيتا بلوكرز بري اوبرتيفلي، لقيتها انه مناح بالذات بالديث بكم هالاوتكم هدول. ف انتم بهالحاله هي بدكم تلاقوا جواب نهائي، لانه هلا في اذا كلينيكال ترايل انت بتعرفها وقاريه بواس واللي هي مشهوره وكبيره وضخمه، وفي هو عم يقول لك في كلينيكال ترايل ثانيه هو قاريه كمان عم تقول الاتجاه المعاكس للإيفيدنس اللي انت شايفه. فبهالحاله هي انتم بدكم توصلوا لجواب نهائي، ويعني بهالحاله بتدوروا على سيستماتيك ريفيو ميتا اناليسيس. من اكبر الموتيفيشنز، من اقوى الانديكيشنز لواحد يعمل سيستماتيك ريفيو ميتا اناليسيس انه يكون في conflicting evidence بالليترشر، يكون في دليل بيقول هيك ودليل ثاني بيقول اتجاه معاكس. فهون يعني هذا من افضل الامثله واحد يعمل سيستماتيك ريفيو، مراجعه منهجيه وميتا اناليسيس if possible. فانت بتدور على وحده معموله اصلا، فبتلاقوا هي انت بس تعمل سيرش بتلاقي هالدراسه هي واللي هي بالسيركيوليشن very good journal. وهي اصلا هي الدراسه الميتا اناليسيس ما انعملت هيك يعني واحد خطرته الفكره وعملها، انعملت بهدف واضح Oh, I'm sorry, Joe is on the line. Oh, I didn't know that. Sorry. So I'm guessing, Joe, you did already read what we were discussing in Arabic. So I'll just completely switch to English now. So then you search with the anesthesiologist on the team taking care of this patient. You search together, and then you find the systematic review. But now, after you find the systematic review, you need to take a look at the systematic review and not just read the conclusion or the result section. You need to really, should you trust the systematic review? Yeah, it is published in Circulation, and yes, it is. It was requested by the specific task force formed by the American College of Cardiology and the American Heart Association to find evidence on this question to actually include in their guideline that they're going to update after 2014. And then you guys find the systematic review. So you go ahead and take a look at the systematic review. So this is it. We had already sent it out. So I'm going to ask a question here prior to actually delving into the systematic review. I'll ask this question right now. Please take a minute to answer the question. And while you guys are answering, I'm going to ask Amar to maybe start recording, because on my end it seems like it's not started yet, but I'm not sure if it doesn't have to. Maybe it's only your end it should.
I am recording.
Got it. Okay,
no worries.
perfect. Okay, I'll count to 5 and stop the poll. 3, 2, 1. All right. So the majority, 2/3 have read it, and some have not. It's okay. So to go back to it, you guys can still see the paper now. Is that correct, Ahmad?
Yeah, paper is clear.
Okay, sounds great. So to start with, you can of course read it fully, and then you make your own judgment of it, or you can listen to what they tell you that its pros and cons are, limitations, what they find, and everything. Or you just, you can let them lead you and actually tell you what to think of it, or you can appraise it yourself and make your own judgment of it. But to do so, you need to have some sort of a structure to actually analyze this paper and dissect it in sort of an anatomical way and a very systematic way of going through it from beginning to end. And to do so, there are several ways. One of them is a checklist like this here. So this is sort of a structured way to go through any paper generally. So any clinical paper, it has to answer at least these 3 questions for you to make your judgment for it. The first question is, are the results valid? The methods behind this paper, are they trustworthy? Can you trust what the authors did here, and can you just take the results and believe it? So that's the first question. Second question is, what are these results? So after you actually trust the results, you need to look at what they say. Is it a good is it showing benefit of what's being compared and evaluated here, or is it showing harm, and how much so? And the third thing is, after you've trusted the results, after you know what the results are, then the third final step is, can I apply these results back to my patients? So we'll go through them one by one. So the first one is, are the results valid? Can you trust the results? This is basically talking about the methodology aspect of the study, of the systematic review. And people who have done systematic reviews before can probably tell a lot about the methodology of it and what's entailed there. People who have not, that's okay, but you should still be able to read one critically when you're faced with it. So the first question, did the review explicitly address a sensible question? So in other words, did they ask a question that they should be asking to answer your own question for your patient? So in other words, they're talking about the PICO, which is also another structure to anatomically analyze a research question. And this is true for many other study designs, not just for systematic review. So for this purpose, I'm going to have to allow people to chip in here and actually tell me what they think the PICO of this systematic review is. Will you take care of it, Tamar, or?
Yeah, sure. Dr. Lubna, would you like to tell us what you think the PICO for this session was, or the systematic review was?
Yeah, okay. While I read it, I see that about the first group of question to appraisal, the systematic review, I think yes, it's address a sensible question. You want me to talk about the result or the first group only?
What do you think the PICO what would you say the PICO for this systematic review was?
Yeah, I say that it's okay, a sensible question. I think the relevant studies was explained well, and the primary study and the methodologic quality of the primary study was okay, good. And about the result, I think it's it's a good result. And I can take it to and I can use it, I think.
Okay.
Okay. So, yeah, go ahead.
Go ahead first.
Okay. So yeah, this is good input, but we'll try to go back to where we are now, and we'll try not to jump ahead too much. But yeah, some of your comments are good to discuss a bit later. But for now, for the PICO, so you think it's a good question, but for others that might need some more justification for why is it a good question, it's a good way to just go through a PICO structure and try to see what is the question here exactly. I mean, especially for complex studies and really long and huge ones like this one here, that do undertake a lot of bureaucracy and do actually conform to a lot of guidelines in terms of writing the systematic review, especially for task forces, as by the AHA. They have to go through a lot of formalities. So it might be difficult for some people to actually just understand it compared to a lot more simpler study published in a less demanding venue, so to speak. So here, let's go through what is the PICO exactly. So the objective of the systematic review was to review literature systematically to determine whether initiation of beta blockade within 45 days prior to non-cardiac surgery, so this seems like the intervention, reduces, and then these seems like the outcomes, 30-day cardiovascular mortality, morbidity, and mortality rates. So morbidity and mortality within 30 days after the initiation of this beta blockade, and that was initiated within 45 days prior to the surgery. So 30 days after the date of the surgery, what are the morbidity, the cardiovascular morbidity, and the cardiovascular mortality rates? This is basically the outcomes addressed by this review. So that's P, I'm sorry, so that's intervention, that's I, this is the intervention, and this is the outcome. Then what is remaining here? There's P, right? There's P, and there's comparison. So what did they compare it to, and what were the patients? So obviously the patients are patients that are undergoing surgery, any kind of non-cardiac surgery, and so that's the patients. And the comparisons, if you can read further, so they searched a lot of databases for RCTs and non-RCTs, looking for let's go back here a little bit. Yep, looking for studies that are comparing perioperative beta blockade with inactive control. So basically any inactive control, whether that was placebo or, well, probably placebo is going to be the most of the studies. But generally speaking, any inactive control. So that's the PICO. So that is our PICO, basically. Patients are any patients undergoing non-cardiac surgery. The I is going to be intervention, which is within 45 days preoperative beta blockade initiation, beta blocker therapy, comparison to any inactive placebo, any inactive treatment, and the outcome is going to be 30-day mortality, cardiovascular mortality, and 30-day cardiovascular morbidity. So given this structure now, I'm going to have to ask what everybody thinks. What do you guys think of this first question? Is it good enough to answer our patient? And is it well formulated question? Okay, I'll let you guys have 10 more seconds. Meanwhile, Amar, can you please add all the other attendees to the panelists so maybe we can hear what they think too?
Yeah, of course.
Given that's a very small number of people. Yeah.
I'm going to add all of you attendees as panelists. If you could all mute your microphones, I'd be very grateful. Allow me to speak in Arabic to make sure everyone is okay, is understanding us okay. نستأذنكم إنه هتكون أجزاء كبيرة من هالجلسة باللغة الإنجليزية. لو احتجتوا أي مساعدة يا ريت تقولوا لنا برفع الإيد أو طرح سؤال على المنصة. رح أضيفكم أنا كبانلست على المنصة بحيث نقدر نتناقش معكم. يا ريت الكل يعمل ميوت، يعمل يطفي الميكروفون تبعه من خلال الزر اللي على المنصة اللي فوق.
Great, thank you, Amar. And guys, you should be muting yourselves now, but whenever you feel like you want to say something. Oh, so panelists can't vote?
No, unfortunately, panelists can't vote. Would you like me to put them back as attendees and ask them to lift their hands whenever they wanted to speak?
I think that would be the best course of action. Yeah, I think that would probably be the best way to go through this.
I could also unmute the attendees and then they could talk whenever you ask them to themselves.
I think that would probably be the even better.
Okay, no
to make it more interactive. Yeah. Okay. So some people said no, and most people said yes. I'd like to hear one of each. So anybody said no, and why? Why so? Why do you guys think it's not a sensible question? I'm not sure. It doesn't show me who said no, but I'd like to hear what you guys think. Nobody said no? Somebody said no. Okay, let's switch back. Let's see who said yes. Anybody would like to justify why yes? Come on, guys. It's a safe zone.
Would anyone want to answer? Does anyone want to answer Faris's question about the previous poll? Dr. Lubna?
It's okay. I mean, it does take some courage to actually just speak up, but it's okay.
Okay.
You don't want to. Go ahead, Lubna. Yeah.
Okay. For me, I think the question is specific and clear. I don't know. I see it like this.
Great. All right. Sounds good. Thank you. All right, let's move on then. So the second part of the critical appraisal of this review is, what's the search for relevant studies to be included in the systematic review? Was it detailed enough? Was it exhaustive enough? If you can, Amar, please add all of them as attendees so I can start the next poll question.
I can't make panelists who I've already added. I'd have to take them out and they'd have to sign back into the whole webinar.
Oh, all right. No worries then. All right, let's just speak up then. If anybody would like to say something, the attendees can vote and those panelists can speak up if they want to join. What do you guys think? So you have to go back to the study. I'm hoping you guys either printed it or have it open on your own computer. And you have to go to the section where it talks about this specific aspect, the search. And tell me what you think. Okay, people are voting, but anybody would like to speak up meanwhile?
Dr. Lubna, if there's any input you want to put, feel free to go on.
Okay, for the second question, In some search, in some research, about some research, yes, it's I found it detailed.
Okay.
So I think in the most of the research, yes, it was detailed for me. Okay, it's good.
Okay.
Yeah.
All right.
Okay, we
Perfect.
have Ahmed Khalil.
Uh-huh.
Ahmed. And Fatima Abbas, who unmuted herself as well.
Yeah, go ahead. Go ahead, Fatima.
I'm not sure if they're going through some technical difficulties, but they had both expressed that they wanted to chip in.
Okay. 2 more seconds for the poll to close and for people to share their opinions of this question. All right. So 60% of you guys voted, and all of you guys voted said yes. Where can you guys find this section? I'd like it to be more interactive. If you guys want to speak up, please go ahead. There's no right or wrong answer. You can just really say what you think. Yeah, Ahmed, go ahead.
Yeah, so are we in the question about was the search detailed and exhaustive?
Mm-hmm.
Yes, so I see that yes, the search strategy was quite comprehensive. It included the main major databases, PubMed, Cochrane, Embase, and in the supplementary provided by the authors, they stated exactly the search terms that they use, and I see that they are well prepared and comprehensive to include the. So that's the any important studies. Also, they did some manual research. So I see regarding this point, they have.
Mm-hmm. Awesome, awesome, great answer. All right, so it does seem very detailed. They did actually explicitly say all the databases that they search, and specifically, if you guys want to really very well actually evaluate this aspect of a systematic review, a few points actually you need to take into consideration. First of all, who did the search? Is it the authors, the researchers that did the search? And most of these are MDs, so they don't really have a lot of librarian background in terms of their training. So they might not be the best fit from a technical aspect to actually conduct a comprehensive search for a systematic review. So typically the best search is usually done by a librarian, by a trained librarian who actually knows how to conduct the most comprehensive search that's reproducible. So that's one aspect. The second aspect is date-wise. So in addition to what databases they search, you also need to take a look at the dates that they search these databases for. Typically, the best way is to search databases from their inception, the point of inception, the very first point in history where these databases were created, so at the beginning of time for these databases, to the very present day that this paper was published. It doesn't have to be the exact day, of course, but it has to be close to it. So here, if you look at the, let's see, this is going to be the third page of the systematic review. Let's look at it together. Now let's go to the methods section, specifically to the search strategy. So they looked at these databases. They also hand-searched abstracts for conferences and scientific societies, which is great. To hand-search, not just rely on an online search, because a lot of older literature might not be available online, and specifically for abstracts. And this occurred between January 2011 to April 2013. This paper was published in 2014, so that's pretty close. That's not too far away. But if it was, for example, April 2013, published in 2016, there's a lot of time that during this time between the end of the search and the publication of the paper, of the systematic review, there might have been many studies that have been published that were not included. So in other words, this would then be, although it was published, let's say it was published this very day, April 15, 2017, but the search was in 2015, then although it is published today online, it's a very new paper, very fresh, it's actually out of date. It's obsolete because we can't trust the evidence because, well, I mean, of course it's different for different fields because some fields have a lot of output in terms of research, a lot of studies that get published there, compared to other fields like dermatology. There isn't a lot of research that's published every day. For example, in comparison to cardiology, where there's a lot of evidence that's published every day. So it's different for different fields, but generally speaking, there has to be a close proximity in terms of the dates of publication of the paper and the end date of the search used in the systematic review. I hope this makes sense to everyone. If you have any questions, please go ahead, write in the chat box or raise your hand. We can definitely discuss your question. So going back to our sheet here, was the search for relevant studies still exhaustive? I think we all agree that yes, it is very well done. Now the next point, were the primary studies of high methodologic quality? So the primary studies, they're talking about the included studies in the systematic review. And where they talk about methodologic quality, then they're talking about the risk of bias assessment. Every systematic review must have a risk of bias assessment of the studies it includes. If it doesn't, you might as well just throw it in the trash because it's not useful at all. So there has to be quality assessment of the studies that a systematic review includes. To take a look at that, you can go to the results section, because here we actually started now looking at the results section. And specifically in the results section, we have to look, depending on how the paper is written, either outcome specific, which is the best way to actually report the methodologic quality of the included studies, because it's different for different outcomes, especially in terms of follow-up, in terms of loss to follow-up, so follow-up in terms of length of time, and then follow-up, loss to follow-up in terms of number of patients. So these are two different aspects of follow-up. And other aspect of quality assessment that we're going to talk about now as well. So let's take this is the results section. We can go ahead and read through it. I hope you did. So we have 17 studies included. 16 of them are RCTs, and one is a retrospective cohort study. I'm not sure if it's retrospective. It's a good size, but let's just say it's an observational study. I'm not sure if it's retrospective or prospective. But so it's 16 RCTs and one cohort study that's included in this systematic review. To start with the outcomes, the first outcome they talked about is non-fatal myocardial infarction. And for that outcome, they said that 16 RCTs actually reported this outcome that they included. And where did you guys see the risk of bias assessment? Do you guys see it anywhere? Anybody?
There's a table later on to look at like various types of biases they're concerned with.
Which page is that?
Let's see here. 5 of the supplement, page 5 of the supplement section.
Yeah, exactly.
Great. Awesome. So, did you guys see this figure? So this is the figure that sort of graphically represents the quality assessment of the RCT. So these are the 16 RCTs included. And then here is a table for the observational study. So it's a single observational study. And for these 16 RCTs, I hear there's a question about gray literature. Very good question. So they used, yeah. So in terms of methodology, Samir said that the methodology quality was assessed using the Cochrane risk of bias tool for the randomized controlled trials in Newcastle, Ottawa for the cohort studies. That is correct. Thank you for your input. Great. I just thought actually. So if you can, if you'd like to, share verbally in time, that would also be appreciated. But thank you. So yeah. So they use different tools, obviously, because for different study designs, you have to use different tools. For RCTs, the best tool that's typically used is the one developed by Cochrane Collaboration, which is for risk of bias assessment of RCTs, randomized controlled trials. For observational studies, there are so many tools actually, and none of them is the best. So there's no gold standard, and it's hard to say which is better. But there are a few that are acceptable in terms of their reproducibility and validity and fidelity. And one of the most widely used ones is the Newcastle-Ottawa tool. So let's take a look at the risk of bias assessment here. What do you guys think of the studies? Just looking at this right now and looking at this section only. So this part of the table. Yeah, go ahead.
Yeah, I would just like to point that more than half the included trials are of high risk of bias, and actually some of these trials, like the boys trials, will have a large weight in the forest plot, which represents the results. So this make me have some concerns about the results and how can we rely on them being of high risk of bias.
Okay, good point. And you said the PWAS that you were most concerned of?
Yeah, but more than half the trials are of high risk of bias. If you count them, more than half of the included studies are high risk of bias.
Okay, and that's your judgment of all the study itself, right? Or are you talking about specific aspects of it?
No, I see that the blinding being these trials evaluate medical treatment. So I think that the blindment should have been better than that. It is not a surgical treatment that we cannot hide this from the patient. It's a medical treatment and placebo. So I think that the blinding in some trials should have been better than that.
Okay, all right, that's a good point. So anybody else would like to share their opinion?
I think that the fact that the decrease study was also both like the associated decreased RCTs had an issue with blinding is probably more concerning too, because that's kind of a big point of what they're the outcomes they're trying to look at. They're very different than some of the other studies. So probably important that that one also has a high risk of bias.
Okay. All right, good point. Does everybody agree with what's been stated so far, or do you guys have any comments? Do you guys all agree with what Ahmed and Georgia said? Yep, go ahead.
Yeah, I think I agree with Ahmed. I agree with him.
Okay.
Yeah.
All right. Well, I actually disagree with you guys. I mean, of course, you guys have a very good point in terms of looking at the red color here. But it's really the best way to be more sort of specific in terms of your judgment. So I think I heard Joe said that the blinding aspect, and Ahmed, the blinding aspect of these of some of the studies, actually a good number of the studies, is not that trustworthy. So there's no blinding, in other words, of personnel that are conducting the studies, that are giving the intervention, actually, taking care of the patients and of the patients themselves. So that's a major flaw, especially in RCTs that are providing different findings, actually opposing, conflicting findings, completely opposite to each other. So that's a major flaw. If the studies were mostly agreeing with each other, then we might think maybe this is effective, maybe it's not so much effective in terms of how we trust the results. But if they're actually opposing each other, then we definitely take it very seriously. However, I don't think most of the studies are actually of poor quality. I think most of them are actually of acceptable quality. I mean, it's like moderate risk of bias, I would say. And if you look at the text, they did actually say that it was sort of, let's go back to the text, 1 second. Let's go back to the results section. So here, as you can probably see, guys, of the 16 RCTs that I included, 8 of them had low to intermediate overall risk of bias. Overall risk of bias is basically when you try to combine all the aspects together and just make your own subjective judgment of the study. Do you trust it? Do you think it's at low risk, intermediate risk, or high risk of bias? So this one seems like it's intermediate to low risk of bias. This one a little bit higher risk of bias, actually quite high risk of bias. This one probably the same thing. This one intermediate to high, and then intermediate to high, low, intermediate to high, low, 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 intermediate to high. So overall then, when you look at the whole body of the studies that have been included, you could probably say it's intermediate to high, and for some studies, low to intermediate risk of bias. So that's the overall judgment. So basically, you can interpret the findings of these RCT in light of their methods, in light of the quality that they were conducted with. So I'm going to ask you guys now, well, yeah, so this is the 16 RCTs, but there's one study that wasn't an RCT. It was actually an observational study, which was by the evaluated by the Newcastle-Ottawa scale. So selection. It doesn't say what these 3 asterisks are saying. Actually, I've even looked below, but it didn't say. So it probably was just missing from their supplementary material. Anyway, so selection, basically selection of patients. The best selection method of patients for an observational study is its consecutive patients that have been enrolled. But when you select patients, when you say, for example, patients that come on Wednesday, patients that come on Tuesdays, patients that come at this time of the day, although this might seem arbitrary to you and random and maybe perhaps non-biased, it's actually not the best way of enrolling patients in observational studies. The best way, especially for prospective observational studies, is to actually take consecutive patients. So basically take everybody, and then you actually include or exclude them based on your clinical criteria. So it doesn't say here what exactly they thought of selection. Comparability, 0 stars. Oh, I'm sorry. Yeah, so this is basically what they think of the equality. So there are different ways to report the Newcastle-Ottawa scale, either using stars or using verbal statements like low risk, high risk of, or intermediate risk of bias. Study findings. Basically, I think what they thought of it here is that it wasn't of high risk of bias, in other words. So it was acceptable. So I'll ask you guys now what you think of the overall body of evidence reported in this systematic review in terms of quality. Do you think it's high quality? Do you think it was low quality? Or do you think it was, or you're just not sure? Okay, I see someone said high, someone said low. Another high, another low. Low, okay. Great, and specifically for this aspect of actually evaluating the quality or risk of bias of evidence, this is the most subjective aspect of evaluating clinical research. Like what we're going to see later with the numerical part, statistics, and the findings, we can be much more agreeable with each other, especially if we discuss and actually convince the other person. But for the methodologic aspect and the risk of bias, because it's risk of bias, it's not actually judging that this study has high bias. You just say high risk of bias, because some flaws predispose the study to having bias, but they never say that a flaw actually leads to bias. You know, it leads to risk of bias, probability of bias. Does that make sense? I hope it makes sense to everybody. All right, 50-50, which is actually the best way of looking at the systematic review, because it's exactly what the figure, this colored figure was saying. It was actually sort of 50-50. So I think this is the best way to look at the study. You don't always have to agree with everybody in terms of risk of bias of a study, but you have to have a good reason for your judgment, for your own judgment, if asked. All right, so next section, let's move on to were the assessments of the included studies reproducible? So this question particularly is not typically found in other checklists like the CASP, like some other clinical critical appraisal checklists for evaluating systematic reviews. But they included it here. This is by McMaster. And what they mean by it is, did the studies, or in other words, were the studies on the same page, or were they different from each other in terms of methodology? Do you think that if the same studies that you included in your systematic review, if the same studies were conducted all over again, do you think they will reach the same conclusions and the same numbers that they reached this first time? And the way you make this judgment is basically by looking at the specific of the methodologies used in these studies. So this question particularly will take more time to answer because you will have to go back to the individual studies included and make your judgment of whether or not you think that these methods are reproducible. So we're not going to do that here because it's going to take many more hours to actually do that. But an overall impression of what we've read from and what we're going to read too, because there are quite big differences between the studies included, like we're going to discuss in it, especially with the decreased trials, the decrease 1, decrease 4. There are methodologically and in design different from the rest of the trials included. So in that sense, I would say maybe yes, most likely yes, but not completely yes. We're not going to discuss that much here. So the next one. So we have answered, are the results valid? So at this point, do you think the results are valid, or do you think the results of these studies are not valid? Just before even looking at what the results are, try not to be impressed or sort of discouraged by the results of the study, and try to be impartial and just look at the methods and think, am I going to trust the results of these?
So Faris, you just cut out there, sorry. Could you repeat what you just said?
What was the last thing I said? Where did I cut out?
You were just repeating the question. It was just your last sentence.
Okay. So basically, I was just saying that we have discussed this section. So far, do you think the results are valid, or do you think the results are not valid? What do people think so far?
I guess my thoughts are that it seemed like they had a well-designed kind of PICO format of what their question, what they wanted their question to be, and they seem to appropriately review the literature for that. Again, kind of looking at the studies that they have available, several RCTs. So, I mean, based on the setup that I've seen so far, I feel like the results that they're going to get are worthwhile looking at, and they set up the process well to yield good results.
All right, thank you, Joe. Anybody else has any other comment too?
Yes, I think okay, it's fairly reliable, not an excellent, but it's acceptable because it contains RCT. Although the RCT, we don't know the details about it, but I think it's acceptable.
Great.
Not excellent, but acceptable. Okay.
I see what you mean.
Yeah.
Great input from both of you. Thank you.
Yeah, I would like to add something if possible.
Sure. Yeah.
Yeah, actually, as I'm not an expert also, but I had a thought while seeing the table of summary concluded studies. I see that there are marked difference between the different studies, like the type of the surgeries, the years the study was performed, which mean different techniques or different methods of anesthesia, and even the surgery itself. So I think there are some sort of clinical heterogeneity between the studies. So it made me think, is it reasonable that we combine the results from all these different studies in one meta-analysis, taking into consideration that they are very different within themselves, even if we compensated for the statistical heterogeneity by using random effect models, but still the clinical heterogeneity are some sort of an issue for me.
Yeah, that's a very, very good point. And when you said you're not an expert, I think you're taking yourself for granted. I think you have very, very good knowledge of what you're talking about. This is great, actually. That's a very good input. Yeah, I agree. And we're going to delve a little bit now, actually, into the heterogeneity part and how the studies are different and how they are actually different, especially in definitions like Ahmed you were mentioning. Great input. Thank you, three of you. All right, so let's talk about. So yeah. My take on this is that yes, I would actually take these studies, take the results of these studies, and actually see what they're what they're telling me. But I would not 100% actually trust all the methods that use in all these studies. So I would still take them with a grain of salt, with a little bit of questioning eye in terms of how these studies actually reach these conclusions. So I would be a little bit conservative in how much I trust the results that are coming forth right now that we're going to look at. But I would generally be interested in what these studies are saying. So there is some truth to what they're saying. Basically, that's what I'm saying. So what are the results? What are the numbers that these studies are telling us? To start with, what are the overall results of the study? And obviously, you have to go to the results section to get this. So from the abstract, you can see that a quick look at the results. 17 studies included, 16 RCTs, 1 observational study, quite a large number, 12,000 for the RCTs, and 350 for the cohort study. They're actually starting to separate the studies from each other. So they're talking about, aside from the decreased trials, the 1 and 4 that are included here, two decreased trials, all the RCTs initiate a beta blockade within 1 day or less prior to surgery. All right, and then this decreased trial, as we'll see later, actually initiated their beta blocker treatment 2 days or more prior to surgery. So within 45 days, yes, but 2 days or more. But all the other RCTs, they started the beta blocker 1 day or less prior to the surgery. So just looking at this alone, you can just like Ahmed said, these are a completely different set of studies, because the intervention is actually quite different. In all the studies, in all the RCTs except these two, they started the treatment within 1 day or less, and the rest 2 days or more. And when you go back to the details of these trials, it's actually more than 2 days. So this is basically 2 different interventions, but they're quite overlapping. So they're similar, but they're not exactly the same intervention. So this is clinical heterogeneity. That's a huge factor leading to a lot of clinical heterogeneity between the studies. And this has had a lot of impact to lead to different results. And indeed, it does lead to different results from these 2 trials compared to the rest of the RCTs. Now, among the RCTs, beta blockade decreased non-fatal myocardial infarction by almost 30%, so 70% of relative risk. Confidence interval, statistically significant. So it's not including the value of 1, and this is a ratio. Value of 1 means there's no difference between the 2 interventions, and it's not including it, so this is confidence interval suggesting statistical significance. So it decreased myocardial infarction, but it increased non-fatal stroke quite a bit. Relative risk of 1.76, that's significant. And then increased hypotension, also quite a bit, that's statistically significant. Increased bradycardia, wow, a lot of increase in bradycardia. So generally speaking, relative risk of larger than 2.5, this is a large effect. Less than 2.5 or 2 is an increased relative risk, but it's not a large effect. But more than 2.5 is large, more than 5 is extremely large effect. So this is a big increase in bradycardia in patients that have started beta blocker, understandably given the physiology of it. And these findings were qualitatively unchanged after decrease, and post-1 trials were excluded. So post-1, as you'll see later in the first plot, is actually a huge trial, the biggest of them all. So it has the most effect on these confidence interval, on these effect measures from the meta-analysis. Mortality. Effects on mortality differ significantly between the decreased trials and the rest of the studies. So the decreased trials basically said that well, we're going to actually look at it here. Decreased trial showed that there's decreased mortality, which is why they call it decreased trials. They saw decreased mortality with the initiation of beta blocker in these patients. However, the rest of the studies showed increased mortality. So this is what the anesthesiologist and you were talking about. So you were basically saying that you looked at the POIS trial, and that showed increased mortality with beta blocker. But the anesthesiologist had read the decreased, maybe both of the decreased trials, and said that actually it decreases mortality. And this is why we're doing the systematic review. But in your systematic review, both of your studies actually were included, and now you're sort of confused because how do you interpret the results? That's what we're going to do now. Beta blockers were associated with a trend towards reduced all-cause mortality in the decreased trials. Quite a bit, actually, about 50% decrease, which is a big difference, big decrease. But increased all-cause mortality with the rest of the trials, which also quite an impressive increase. I think it's 1.3. And that's the same for cardiovascular mortality rate as well. All right, so this is a quick snapshot of the results. Now to go back to them, now actually to go deep into them one by one, let's go to their full text results section. So the non-myocardial infarction, we're basically saying the same thing as in the abstract. So the relative risk, the pooled relative risk is 0.68. But when you actually separate the decreased trials from the rest of the RCTs, it's even more. But it's basically saying the same thing. There's decreased non-fatal myocardial infarction. So from this, you can basically say, although these decreased trials were different, but in this outcome, they were saying the same thing. So here there isn't a lot of heterogeneity, and you can say with good, with a high level of trust that beta blockers actually decrease non-fatal myocardial infarction in a statistically significant manner. All right, so this is what the results say. What are the results for this outcome? Now another outcome, fatal stroke, basically the same way as you have probably read it, that when you take the decreased trials out in what's called a sensitivity analysis, the effect measure is unchanged. So there is still increase in non-fatal stroke. Beta blockers decrease myocardial infarction, non-fatal myocardial infarction, but they increase non-fatal stroke. So far, we're on the same page. We're trusting what the studies, the body of evidence is saying. All the studies are saying. They're all on the same page. They're saying the same thing. Decreased MI, non-fatal MI, increased non-fatal stroke. When we get to death or cause death, as we saw the abstract, this is where the studies actually start to get very different from each other. So the decreased trials, because of their different definitions of the intervention, because they started the intervention differently, so that basically they had some sort of a different design compared to all the rest of the RCTs. They had been reporting the opposite effect size in terms of all-cause death, and we'll see a cardiovascular death too. So the decreased trial, we're saying there's a decrease in all-cause death, but the rest of the studies were showing that there's an increase in all-cause death. But now, given the risk of bias assessment, given the quality of evidence in the decreased trials, we're tending to trust the rest of the studies, the rest of the RCTs, and not so much trust the decreased trial. So we're questioning the results of the decreased trial at this point because of this. So we are tending to trust the rest of the RCTs that are saying there's an increased risk of death, all-cause death, by use of beta blocker. All right? Are we all on the same page so far? Anybody has any questions?
I don't have any questions showing up here as well. Nothing.
All right, sounds great.
Everyone's fine.
All right. So now the next outcome of death is the specific outcome of cardiovascular death. So death from cardiovascular reasons. So the RCTs were showing that there's an increased risk of cardiovascular death. In the decreased trials on the other side, however, there's a decreased risk of cardiovascular death. But we said that we're going to be questioning the results of the decreased trials, so we're going to be trusting the results of the RCTs, the rest of the RCTs. Perioperative adverse events is not an outcome that's interesting to us at this point, so we can go through it later if you guys want to read it on your own, but it's not relevant to our clinical scenario. So far at this point, what are the results of this systematic review? Anybody would like to share their opinion?
دكتورة فاطمة. Anyone else? دكتورة لبنى أو دكتور أحمد. If any of the attendees wants to participate verbally, we'd be more than happy as well.
Actually,
Sure.
I have a question, not an opinion. Shall I say?
Yeah, absolutely.
Yeah. So when we had that the decreased trials and the rest of trials are going in different directions, so are you telling us that in such situations we should go back to the risk of bias and neglect the trial with the higher risk and go with the rest of the trials? So from the start, why are we adding this trial to the first plot and seeing its results if we are going to do that whenever we see that the risk of bias are not in its favor?
Yeah, that's a very valid question. Thank you. That's a good question. So, so there's a golden rule in systematic reviews, in the conduction of systematic reviews, is that you should not exclude unless you have a very, very good reason to exclude. So a decision of exclusion of a study from a systematic review is basically, you're basically saying that this study does not exist, because a systematic review needs to be comprehensive to the point that it includes all the available studies, all the available literature relating to a specific question. So when this study is making exclusions based on quality assessment, you can say this is not a very good systematic review, not a very well done systematic review. A systematic review needs to be very inclusive of all the eligible studies answering its question, regardless of their methodology. However, when you do the analysis, at that point is actually where you can do subgroup analysis, or sort of a sensitivity analysis. Sensitivity analysis, as you guys can probably see from the forest plot here, sensitivity analysis is basically saying the good studies, the studies that were done well, you can put them at the top, and then you can actually have a pooled analysis, sort of a small meta-analysis for only those with the subtotal here. So that's the overall effect measure. Okay, this is the pooled relative risk. You put the rest of the studies that you think are at low quality, excuse me, you can put them on the other side, on just below, with their own meta-analysis too, with their own pooled relative risk. And then you can have an overall relative risk of all the forest plots, of all the included studies in the forest plot. And then you can actually let people make their own judgment in light of your assessment of their quality. So you would be discussing the quality later, like we saw in the figure below. And then in light of that quality, you can look at these studies and what they're actually saying. And then you can let people decide for themselves which of these effect measures to take and believe. But I mean, it's a logical question. If it's bad evidence, why should we even include it? So the golden rule is we do not exclude, and that's for conduction of systematic reviews, you do not exclude studies based on quality assessment. Does that answer your question?
Yeah, actually, give me a good point. Thanks.
Okay, great, awesome. All right.
Okay, just to point out, we finished the first hour, so we might want to plow through the rest of the 15 minutes we have left.
Yeah, we're almost done actually. We're pretty much done. So we've discussed the bulk of the paper basically. So we've discussed the quality assessment, we've discussed the method section, we've discussed how the systematic review is done, and now we're just sort of going through the results. And when you're going through the results, you should not only read the text, you should definitely look at the graphs, specifically the forest plots. And I'm assuming you guys know how to read a forest plot, but for those who don't, I'll just go through it just fairly quickly. So a forest plot has list of the studies included, has a line, and this line is at the point of no difference. So what that means is that if the effect measure we're calculating here is relative risk or relative ratio, that's the ratio. So that ratio is at point of no difference between the two groups when the ratio is 1, which is why the line is at the point of 1. So to the right of the line, there's increased relative risk, and that means it favors control. So increased relative risk of, here this is 30-day mortality, non-fatal MI, in hospital or non-fatal MI. So this is the outcome of non-fatal MI. So increased relative risk of non-fatal MI is a bad thing. So it favors the control, not the intervention. If it's decreased risk, favors the intervention, beta blockers. And then these points, these are the relative risks reported by the individual studies, and the line itself is actually the confidence interval, where it starts, where it ends. And this is the like we said, the relative risk of individual studies. So, and by the way, the size of the box generally means the weight of the study. So how much is the study affecting the overall relative risk, the results of the meta-analysis? And a rule of thumb is the larger the study, the more patients it has, then the more it's actually able to affect the overall risk, the overall relative risk, because it has more power. So the more patients you have, the larger the N, the total number of patients included, the larger the power of the study, and therefore the larger the weight it has in a forest plot. Conversely, I mean inversely, the other studies, of course, the lower the weight, the lower the weight, that means the lower the number of studies included, and vice versa. So as you can see, the PWAS is actually quite large, more than 4,000 compared to maximum of maybe 250 or 450, and then rest of the studies like 15, 20, 15, 20, 100, 99. So it's quite large. So that's why it's sort of driving the whole pooled effect estimate. All right, so they put the decreased trials alone because they were quite different, their definitions of their interventions. And then these studies were very similar in terms of their interventions. So they were homogeneous with each other, and these are homogeneous with each other. But these together all are heterogeneous because of the difference in definitions in the decreased trials. So this is for the non-fatal MI. This is for non-fatal MI, but instead of taking the decreased trials, they completely removed him from the first plot, and they analyzed the PWAS alone. Because it's very large, they thought, how are the rest of the studies, the small studies alone, looking like? And they look not significant, as you can see here. They have the value of 1, and it's actually crossing the line of no difference, this confidence interval of the overall effect estimate. So this means that they were not significant because they were low-powered, because they have low number of patients included. So they have low power, and this study has a high power. So a lot of the times, you might actually have a difference between interventions. The intervention might actually be beneficial or harmful, but if you have a small number of patients, you might not be able to detect that difference. You might not have enough power to detect the difference. So that's why it's very integral to have a large enough number of studies included. All right, next forest plot, non-fatal stroke, like we've discussed. So this study is on the other side, it's basically showing there's decreased risk of non-fatal stroke, and the rest of the studies are showing increased risk. Same thing here for non-fatal stroke by different subgroup analysis. This is the mortality. This is a very important forest plot. As you can see here, the decreased trials are showing decreased mortality. The rest of the studies are showing increased mortality. This is a very important forest plot. And this is the 30-day mortality in different subgroup analysis too. And that's pretty much it. The rest of the forest plots are in the supplementary material. This is an important figure to look at, just to see how this systematic review was conducted. The studies they found, and the screening that they did, additional studies they found, and then the screening that they did, exclusions. You have to have, like we were discussing, you have to have a very good reason to exclude a study. And the best quality of systematic reviews would always report the reasons why you excluded any study. All right, it's a very major decision. And then eventually the studies that were included. All right, now go back to the what are the results. So we discussed what the results are. How precise are the results? The word precise, what do you guys think it means? Anybody? How do you know if the results of a study are precise or they're imprecise? What do you look at?
Don't be afraid to get it wrong, by all means. Fatima, are you with us? I'm trying to find someone who's not talked. If any of the attendees would like to answer this question, again, if you're afraid to speak up, by all means answer through the questions portal.
I mean, I'm not entirely sure. Maybe there's a statistic that looks at the homogeneity of the study results, but if all the confidence intervals cross the overall effect seen within all the studies, I think that would be a useful thing to see, that they're all kind of saying the same thing, and if not, then you'd be concerned that maybe some of the studies aren't really representing what the overall effect was.
Yeah, thank you. Thank you for the input.
If I am to say, I'm not sure, but I think I would look at the width of the confidence interval itself. If it is very large, so I would not consider this as precise, but in case of a narrow confidence interval, I would take this as precise.
Great. Yeah, I completely agree. So you got it spot on. How do you say that a result or an effect measure, like relative risk here, is precise, or if it's imprecise? So relative risk, the pooled relative risk. Well, let's just look at the first subgroup analysis, just these two studies. The pooled relative risk from these studies is actually 1.3 with a confidence interval of 1 to 1.6. So the width of the confidence interval is 0.6. Look at this one here on the other side. The relative risk 0.4 from 0.15 to 1.22. So that's even larger than 1, from 0.6 to 1. So this confidence interval is wider, and you can definitely see that visually from the diamond here. So this is quite different than this one here. And just like you said, the more narrow a confidence interval is, the more precise it is. Now let's look at another one here. For example, there was another that was really weird looking, like this one here. So the first few studies had a confidence interval of 0.26, maybe 0.27. All right. This one here on the other side, from almost 0 to 1.4 or 1.5, and you can see that visually very different. So this is a very wide confidence interval compared to a very narrow one. So this is a very imprecise measurement, a very precise measurement. And for some systematic views, the confidence interval can go crazy wide. Like it can go from, for example, 1.2 or 3.3 to 105, for example. That's extremely wide. That's extremely wide confidence interval, very imprecise confidence interval. And here's a piece of advice. The width of the confidence interval is eventually related to the power of the studies, the power of the included studies. And like we discussed, the power comes from the included number of patients, right? And so this is the included number of patients for this class. 152 here, number of events, which is non-fatal MI for this outcome. Two things. First thing, the larger the study, the more power it is that it has, and therefore the more precise its findings will be. Another factor is also the number of events. The larger number of events, the narrower the confidence interval, and the more precise the confidence interval will be. Basically the findings, they will be more precise. They will be more precise. So these two factors are very important. You should keep them in mind at all times. All right, so how precise are the results? We can discuss that outcome by outcome, but we know how to do that now. Were the results similar from study to study? I think we were sort of discussing that along the way, how the studies are quite different, especially in terms of the outcome of death, all-cause death, and cardiovascular death. Here, these two studies are quite different, so they're heterogeneous, and the cardiovascular death, like we saw as well. So what are the results? We've answered this question. What does the systematic review and its included studies actually said? And then the final question is, will the results help me in caring for my patient? Does it eventually apply? What should I eventually do? how can I best interpret the results and apply them to my patients? So far, from what we've heard so far, we've looked at the quality of the studies, how high or low the risk of bias in these studies is, and we've looked at what they've actually said in terms of results and numbers. So what do you guys think? Do you think beta blocker is good for this patient, or is it not good for the patient? Anybody would like to take a head at this? No one? All right. So yeah, go ahead.
Yeah, can I share? Yeah, if in the light of the current evidence and that the ethical concerns about the decreased study which is in favor of beta blockers, I would say that we should withhold beta blockers for those patients right now. Also in the light that there are previous meta-analysis supporting that the beta blockers are not of value for these patients, but the risk-benefit calculations are not in the favor of the patients. So I say that like the paper included, need of larger multi-center clinical trials to have to say a conclusion. But right now we should not give the patient.
All right. Thank you, Ahmed, for your input. So this is what Ahmed would do. Ahmed would not give beta blockers to this patient. What would the rest do? Would you guys give beta blocker, or would you not give beta blocker to the patient?
Okay, for me, no, because as we see, the result can be considered acceptable, but not strong, not accurate in every cases, in many cases. So I will say no, and there is a need for more meta-analysis or more studies to get the final answer to this question.
I see.
Or
yeah.
more
yeah.
strong answer. Yeah.
Okay. All right. Yeah. We'll go through what they really mean. I agree with all of you, but I would not say we would need more systematic review because we already have one. But I would agree with you that we need more original research. We need a better conducted RCT that actually evaluates a very well-defined outcome and intervention. So I totally agree, Lubna. Yeah.
Okay.
Yeah, thank you. All right. So how do I best interpret the results? Then we actually, I think, discussed that along the way too, that we will be a little bit questioning the results from the decreased trials, but more trusting the results from the rest of the studies, particularly with the outcomes of death, the two outcomes reported in the systematic review, the cardiovascular and the all-cause death. Were all patient-important outcomes considered? So let's go back to our patient here. So this patient, let's go back to the patient, 68-year-old female. She needs to have knee surgery in 5 days. She has this history, extensive history of stroke 2 years ago, hypercholesterolemia, diabetes, and hypertension. But her blood pressure is actually low right now. She's hypotensive somewhat, but she has no other complaints at this point. Given the results of the systematic review, what the beta blocker actually says, I mean, what eventually does in terms of cardiovascular risk, it increases hypertension, so that's a bad thing for the patient. It increases death, all-cause death, and cardiovascular death. It increases bradycardia, but it decreases non-fatal MI. So these are the results of the systematic review. That's basically what the evidence says. So all the patient-important outcomes were considered, very obviously, yes. Are the benefits worth the costs and potential risks? So we see the potential risks are death, bradycardia, and stroke. The benefits on the other side, just low MI. The cost of a beta blocker is not that high anyway. So for our, there was a section in systematic review. You guys have seen it before, let me find it for you. And they did have some other useful statistics discussed. Yeah, so the post hoc analysis, this eventual section here, what they actually said is that you can read it. Basically, what they thought in this analysis is that the perioperative, and that's without the decreased trials that were controversial, that we really were questioning their results and their methods. What they eventually found is that perioperative beta blockade leads to 17 fewer non-fatal MIs, so decrease of 17 MIs for every 1,000 treated patients. But for these patients that were treated by beta blockers, they had 6 more deaths, 4 more strokes. So this is the risk: 6 more deaths, 4 more strokes. The benefit: 17 fewer MIs. In light of this, you can go back to your patient. You can go back to your patient who is hypotensive, who has extensive history of hypertension, so in other words, cardiac risk patients, because of hypertension, diabetes, hypertension, and she already had a stroke 2 years ago. So we definitely don't want her to have any stroke more. We definitely don't want our patient to die. And if our patient, happens to have a non-fatal MI later, I think given that she's in the hospital, we can probably take care of her. But the risk is way higher than the benefit, and the decision eventually is that we do not give this patient a beta blocker. So at this point, I have reached the end of discussion of this paper. But if anybody has any question, or you guys have anything you'd like to discuss, please go ahead.
Yeah, I have a question. So, the conclusions that we came to, that we will individualize the treatments of the decision according to the patient's case?
Yes, exactly. So whenever a patient is high-risk patient, like here, this one here, she has extensive history, and currently she has a condition which is hypotension at this point. Its status is hypotension. Is very much affected by beta blocker, because beta blockade, they do a appalling job for blood pressure control. So we should be very, very, very careful to start beta blockers in hypertensive patients. Very, very careful, especially because beta blockers, typically the best use of beta blockers is that they should be weaned on beta blockers and they should be weaned off beta blockers. And for optimal effects of beta blockers, they have to be used for 4 to 6 weeks prior to actually achieving the optimal level of treatment. So so that is one aspect, okay? And the other aspect, given the evidence available, is that we have inconclusive evidence in terms of how big of an effect it really has. So obviously it has increased risk of death, increased risk of stroke and bradycardia, but decreased risk of non-fatal MI. So because the evidence is not showing a benefit across all outcomes, so to speak, you know what I mean? So because there's risk, there's not just benefit, there's risk. We're sort of being very conservative in our judgment. Does that answer your question? Okay, I'm guessing it does.
Okay. If anyone else has any questions, feel free to reach out and send them over the question portal, or send them after the session. Get in touch on our SAMS Education Facebook page. I apologize for not properly introducing our speaker at the beginning of the session. Allow me to now. We're very lucky to have with us. We were very lucky to have with us Dr. Ahdab, MD, Assistant Professor of Medicine and Postdoc Research Fellow at Mayo Evidence-Based Practice Center in Rochester, Minnesota. Again, if you have any questions, feel free. We still have some time if you want to ask anything now. And if you do want to keep your questions for after the session, I'm sure Dr. Ferris would be more than happy to answer them
sure,
afterwards.
absolutely.
I thank you because this has been one of those sessions when I feel I've been getting a lot out of it as well. And I'm sure
Yeah,
our
thank you.
attendants will echo that. Thank you also for everyone who helped in the discussions. Thank you, Ahmed. Thank you, Fatima. Thank you, Lubna. Thank you, Samir. Sorry, and thank you, Joe, for joining us. I think hope I haven't forgotten anyone. And is there anything you want to add, Faris, before we end the session?
I would like just to add.
Yeah, go ahead, Ahmed.
Yeah, if there is time, I would like to ask a last question.
Go ahead.
Sure.
Yeah. Do you see that the authors didn't make enough efforts to explain the difference between the results of the decreased trial and the other trials? Like they haven't mentioned that maybe this difference is due to the different duration of treatment, the type of the patient. I read the discussion and I see that they didn't they haven't made enough effort to explain this difference. Maybe the decreased trial is not that bad. Maybe it is the right one.
I see what you mean. Well, if you look at the limitation aspect, I think they did have sort of a good rationale of how they treated the decreased trials throughout the analyses included in the systematic review. So because basically there were different definitions of interventions from the decreased trials to the other rest of the RCTs, I think it was a fair treatment of sort of separating them for every analysis, especially the outcomes of death, all-cause death, and myocardial and cardiovascular death. So, in my opinion, I think that they did a pretty good job actually. But if you go back to the individual studies, the decreased trials, you will find that they had started beta blockers quite a bit before the date of the surgery, but the other studies only started it 1 day or less before the surgery. And as you probably know, like we've just discussed, the optimal treatment effect of beta blockers takes some time to actually be achieved. So for that reason, I think that might explain why they have lower mortality compared to the rest of the RCTs.
Okay, thanks.
Yeah, absolutely. I think one last thing, I think it was probably Samir that asked, they did not search gray literature. I think I did read actually that they tried to. Let me take a look. So no language restrictions were applied in the search. Unpublished trials were not sought. So I think that's what you mean by gray literature, which is true. That's the negative aspect. However, they did seem to try to contact authors to ask them to share their unpublished data. And as you know, not a lot of authors actually do that. Not a lot of them actually, are cooperative enough to share the data, especially the raw data or unpublished data, especially considering that beta blockers is a hot topic for a lot of pharmaceutical companies, which is why in the publication bias aspect here, what you will find is that they did actually think that some trials might have shown increased mortality rate were not published. So in other words, when looking at the funnel plot, it was an empty area where the trials that hypothetically should have been published that showed there's an increased mortality rate with beta blockers, but they weren't published. So there does seem to be some sort of a pharmaceutical company or industry, generally speaking, influence on what gets published and what doesn't get published, gets hidden, given that a lot of pharmaceutical companies do support and sponsor a lot of research for beta blockers. So that was a good point, though. All right, so thank you guys for joining. I hope this was quite beneficial to you guys and did sort of expand your horizons and what you think and look at when you read systematic reviews. Thanks again for joining. Thanks again, Ammar, for moderating, and good luck on everything. Take care.